Welcome back to episode 2 of Agilian's MCO webinar series. Last month, Agilian discussed the administrative and financial challenges that MCOs are facing with wrongful disenrollments during the Medicaid unwinding. Today, we have invited our Medicaid experts to share their knowledge of where they're seeing money leakages at MCOs and ways to intervene. Today's topic: where is your money leaking out of your MCO? My name is Barry Jenkins. I am your host and moderator. Welcome back to our returning attendees and welcome to our first time guests. Based on the feedback from our first episode, Reversing Unintended Consequences of Medicaid Unwinding, we are sure you will enjoy and find value from today's subject matter experts. Allow me to introduce today's presenters, Jamey and Diane. Guys, take a few minutes to introduce yourselves, please.
Well, sure. I'm Jamey Harvey. I'm the CEO of Agilian. I'm a serial entrepreneur, and about 25 years ago, I left doing venture-funded companies, and I went to go work for the DC government, where I ended up being the chief integration architect for the nation's capital. And what I discovered there was I had a real passion for working with social equity enterprises to help them fix their IT hairballs, make things work better. So in around 2011, I got invited to work on the Obamacare exchange in DC, and when the project got in trouble, the predecessor company to Agilian was asked to step in and finish that project. So we shipped the first version of the exchange, and we also did the quality control for the Magi eligibility engine, which I was personally responsible for there. And really, I fell in love with the Medicaid ecosystem. So Agilian now really services the social equity, health equity ecosystem around Medicaid. State agencies, payers, and providers that service the Medicaid beneficiaries.
Excellent. Thank you, Jamey. Diane?
Hi, everyone. My name is Diane Gerrits, and I joined Agilian in July. So prior to that, I'd been on leave for a brief period due to some health issues, but I've been with CMS since 2004, working on a variety of different projects related to prescription drug coverage and Medicare, first off as a consultant, and then transferring in, much like Jamey, I caught the passion for Medicaid at that point, and switched from working strictly with Medicare into Medicaid. And I have been involved in Medicaid policy since then, working in both the marketplace and the exchanges, as well as Medicaid and Medicaid finance technical director, and running the 1115 shop at CMS. So I have a real passion for helping beneficiaries access coverage and services.
Excellent. Thank you very much, Diane. And thank you both for being here. FYI, for our audience, you do not have to take notes today. We will be sending out an FAQ document right after today's webinar. Today's agenda will focus on where is money leaking, and then we're going to go through some definitions and sources. We're also going to touch on the impact of organizational profitability and sustainability. We'll have a panel discussion where our industry experts are talking about tackling financial leakages, and then we'll have a Q&A session so we can hear from you guys. What are you experiencing? I want to start this off. Jamey, could you tell us a little bit more what is meant by financial leaks and walk us through some examples?
Yeah, well, it's been a topic that has been, top of mind for payers for the past few years, or for the past, year or so with the Medicaid unwinding. When the public health emergency happened, the CMS issued an emergency rule to allow MCOs not to, and Medicaid agencies not to disenroll people during COVID, right? Which was a terrific piece of public policy, and kept a lot of people covered that might have otherwise been put in danger, at a really critical time. So when the public health emergency was lifted and they decided to unwind that rule, what it meant was that there was a whole backlog of people that had to be disenrolled at once, and it created a lot of business, data, technology, and people problems for folks that were trying to stay on Medicaid and organizations that were trying to do that right. And that's really what brought us into this space was trying to make sure that people maintain their coverage. The framing of this as financial leakages, which is a perfectly accurate framing of it, doesn't really speak to the other parts of this, right? Because mainly what we're doing is we're helping people keep their Medicaid coverage and stay covered, which is, beyond the financial impact that has on an MCO, if somebody's wrongly disenrolled, it has a terrible impact on their health and their health outcomes. And it falls more strongly on people with marginalized backgrounds. So, in addition to the financial problems that this causes, it causes health problems and it causes equity problems, which are the three things that we care about most at Agilian. So, what we found is that most MCOs they have a pretty good grip on their own data, right? And a lot of them are very big companies, so they might have, giant IT departments supporting them in the sky, if they're a state plan. But they don't tend to know very much about the data that exists outside the walls. So they don't know very much about the data that are at their state regulator, what I would call upstream of them, and they don't know very much about the data that's downstream of them with their provider networks and the ACOs and the FQHCs. So what we've been able to do is come with a really simple, unique offering where we take the MCO's data, we mash it up with data that's available from their state regulator and their providers, and maybe even eventually sometimes commercial data, and we're able to give them insights into what's going on with them. And mainly what we've been able to do with that is search like a needle through the haystack, search for a needle in the middle of a haystack, right? And find disenrollments that are not accurate, right? Like people that ought to stay on the plan, but are going to be disenrolled. And this is costing plans, tens of millions of dollars each year. We've done this, 2.5 times now. And each time we're getting more and more confident that this is just an endemic problem in the Medicaid MCO space. Each MCO has a different set of problems, right? And each state has a different set of problems that are being introduced downstream of them. But this, getting your arms around the data for member churn, most MCOs had a really rough year this year, right? There have been rate reductions. There was the Change Healthcare ransomware attack. There was the Medicaid unwinding. So most of them are looking to try and get back to the kinds of profitability that they've had in years past. We found this to be a really effective way to help the MCOs and help the members and help with health equity. And then the other area that we've been asked to look into by a couple of our partners is are people in the right cell assignment? So once that's another way that money might be leaking out of your firm is if you've got people in the wrong PMPM category, so that their care is costing much more than you're getting paid, right? And that is something that should be addressed. So we're basically helping these agencies get at their data and then enriching it with data from outside their organization, from other places in the ecosystem. And we've been able to use that to get to answers very fast for our clients.
Excellent. Thank you very much for that, Jamey. And you kind of touched on this a little bit when you talked about losing tens of millions of dollars. Can you kind of give us a real world example of some of the implications this has on MCO's revenue from these leaks? I know you said tens of millions. That's a huge number, but related to someone that's on this call.
Yeah. So let me say this. First of all, the tens of millions of dollars, we've mainly been looking at high PMPM kinds of plans and rate categories, so that the money adds up very fast, right, when those folks get disenrolled. What essentially we've come up with, half a dozen queries that when we go in, we look at to where we've seen patterns where that people have been disenrolled in other places. So in one state, there was I believe, I can't speak to the actual root cause on the other side with the state agency, but I believe it was a bug in the software at the state agency. It had never been discovered because it was they hadn't exercised disenrollments because of the unwinding. And when the unwinding happened, essentially like a whole group of people, a large group of people got disenrolled, even though they still were SSI eligible, right? And so those are very expensive plans. It looked like it might be economically devastating to our client, and it just didn't make any sense. You know, people who are on SSI that are permanently disabled, they don't become non-SSI eligible suddenly, right? So we were able to go. Essentially, the engagement there was, first of all, finding all those people, building a book of what their data said, and then we mapped it carefully to the regulations, both at the state regulator and then also at CMS, to show that they ought to stay enrolled. And in that particular state, we were able to raise that up, help the plan communicate that to their state regulator, and then get those people re-enrolled before the end of the month so that they didn't lose their coverage. In the meantime, you asked about the impact, though. The notices went out, right? The notices went out saying, hey, you've lost your coverage. You're no longer, and it's a very, very vulnerable population. We're talking about, obviously poor people, right? People that are disabled, their children. So they're at least thrice marginalized, right? Happen to be in an area that's, very urban, a lot of people of color in this plan, right? And so very, very disadvantaged people getting a note that their disabled children were no longer eligible for care, including, a group of people that were in the NICU with newborn babies, right? Like, so imagine you're in the NICU and you get a notice saying, hey, this care, which is, you're watching the bills rack up, it's $150,000 a day, $200,000 a day, is no longer covered under Medicaid. It's a terribly weathering thing to do to people, right? So so I'm sure they were very relieved when they got their care back, but getting to this data, getting to the right answers, making sure the communication is right, has a huge human benefit when you do it right, and a huge human cost when it gets screwed up.
Excellent. Thank you very much for that clarification. And that was a perfect segue into our panel discussion. And one of the first questions I wanted to start off with was, and I want to start off with you, Diane. How can MCOs determine if they're experiencing these structural problems and leaks?
The pandemic really introduced a lot of change, and there weren't a lot of people to facilitate that change at either the state or the MCO, quite frankly, in ways that they had done previously, right? And so, what starts to happen is that as Jamey said, the unintended consequence really just kind of creates a barrier to coverage and care for a beneficiary or a family member of someone. And the problem with that is that CMS, previous to the pandemic, never allowed MCOs to really interact with plans except for one particular state that had a special waiver. So the plans were not accustomed to interfacing directly about their eligibility per se. And then the states also had systems that became disconnected. So all of the new information, everything needing to be processed at once, and all of the people needing to learn the new processes and to go through things, with things being stood up, no regression testing, all of these things, they just created this bubble of people who ended up in a coverage gap potentially. And so the strategy is to get in front of that with the plans and go to the agencies.
Excellent. Thank you. Thank you. Jamey, did you have something you want to add to that?
No, go ahead.
Oh, okay. Now you mentioned things, and it sounds like you're kind of connecting these dots together. So, if you're fitting those dots and stakeholders together, how can an MCO work with CMS or the state to address these issues?
I'll go ahead and start on that, Jamey, if you don't mind.
Go ahead.
Yeah. So, it's a fine line actually between where an MCO can go directly to CMS, right? There are trade organizations that they can work with, and some MCOs have been successful in getting meetings with CMS directly around some of the issues. Typically, an MCO receives guidance and interfaces with their state partner. But being there with your state partner, providing data, providing information, offering suggestions, helping them put together information and data they need for waivers of rules that CMS was allowing and is allowing for the unwinding of the pandemic. Those pieces of the puzzle really can come together well. And that's really where the I guess the intersection of the policy that I've spent years working on, and the systems related policy that Agilian brings together. We can look within the rules and drill in and out based upon different layers that we know, to be able to help just facilitate people talk. You can talk about a problem, but if you can't illustrate it, you're not getting where you need to go for a solution.
Yeah, and I'll jump in there. So from an operational point of view, when we do these engagements, we're generally not coaching our MCO clients to talk to CMS, right? We are more focused on the relationship with the state regulator, but the state regulator doesn't necessarily understand everything about. I mean, they understand a lot about the regs upstream of them at CMS. But the nuances, how it relates to this, the where the pain point shows up with an MCO. Remember, MCOs are still relatively new, right? Like this disenrollment problem is still relatively something people are getting their hands around. And so being able to go to the state regulator with, okay, here's the evidence, right? Here's how it relates to your regs. And then, by the way, like, let's remind you that this also relates to the CMS regs. And let's remind you that there are giant, enormous fines that you're going to get if you disenroll these people wrongly and they complain about it, right? Is a very helpful service to everybody for getting people to move. And there's always this joke when you work in state regulatory agencies and Medicaid that if you've seen one Medicaid agency, you've seen one Medicaid agency, right? They really are, all very, very different from each other, between the waivers and the politics and the whether they took the expansion or whether they're working with MCOs and are they still doing it. They are very, very different. It is much more fragmented than Medicare, for example, right? In terms of how you interact with them bottom up. And so so in every client we've done that's in a different state, essentially we've had to help them figure out how to interact with them. So one of the states we worked in had no process for doing this whatsoever. Like essentially we had to cook up a bespoke way of communicating with them and help them lobby to get the meeting. And at first the state regulator was like, this isn't really our job, like talk to SSI, right? Like that's we think it's their fault, right? So you have to be able to come with a very buttoned down set of artifacts that show, hey, this is a problem and it's your problem and we're here to help you solve it. State regulatory agency that was very effective, right? At the one that was sort of process was relatively immature. Another state we worked at, when we found these, they have a very buttoned down tiger team that's assigned to work these issues. And, essentially we escalated to them. We got a response back in 15 minutes, like they're on the case right now. We haven't gotten the result back from that one yet. Right. Like, so on some level, which one works best, but at the end of the day, it's helpful if you're an MCO and you're not in the habit of having these conversations to have, somebody like Diane who's worked on the federal side, somebody like me and some of our other consultants that have worked on the state regulatory side to help smooth all of that communication, translate the language, translate that into data. What does that mean from a regulatory point of view? Because the data by itself doesn't solve the problem. There's got to be communication, there's got to be interpretation. And of course, there does have to be the right data, right? So it's really been exciting to see how it all comes together and what a big difference we can make for everybody.
Excellent, excellent. Now I have to bring this up because we have our first question from our audience, and it's we're already getting disenrollment data from the state. We check, we check what we can, but what more specifically should we be looking for?
But I think that one probably comes to me. So the for the most part, people are getting their enrollment and disenrollment data from the state in the form of an 834. So an 834, for those of you who aren't in the industry, is an EDI transaction. It's an electronic transaction that carries enrollment and disenrollment data, and some demographic information about the person. So largely, that's sort of supposed to be the source of truth for these records. But what we've found is that on the state side, most of these states have an MMIS system or an eligibility system with a portal that the MCO might or might not have access to, where the data might not match what's in the 834, right? And so, and EDI is if you're a technologist like me, it's a famously rickety, asynchronous, point in time view of somebody, right? So actually, we've gone and looked at 834 longitudinal records, and some of these people that have been disenrolled were enrolled, then disenrolled, and enrolled, and disenrolled, and enrolled, and disenrolled, and enrolled, and this from like 15 times in a 2-week period, right? And so flip a coin which one they ended up on. That's not really how people are supposed to be enrolled in disenrolled Medicaid. That's not to code. That's not to reg, right? That's a problem, right? That's a stutter. It's static, right? So if your business runs on static, it's going to be wasteful. So knowing where there is some place where you can check to actually get to the source of truth, and then knowing how to enrich that data and get it together and figure out, like, okay, which record is right, and then being able to speak intelligently about that to your regulation partners, has turned out to be a real special place where Agilian can provide value for our customers.
Excellent, thank you. Anything more to add on to that, Diane?
I'll just say, as someone who formerly worked in clinical roles and policy roles at an MCO, servicing people, one of the things that the services that we offer can add is somebody on the bridge in the communication across as well, right? So there are innate things internal to an organization, and then things in external data and information, like Jamey talks about, in policy, regulations, et cetera. And I think that bringing that together in a way that we can help interpret that and help people who are very busy actually taking care of beneficiaries, right?
Yeah.
So keep in mind, the goal of the MCO is to take care of the beneficiaries. And so any way that we can help them facilitate that, that's really what we're here for.
Excellent. Thank you so much. And to our guests that are here, please, we encourage you to use the Q&A button at the bottom if you want your questions answered as well. In the meantime, it looks like another one has come in. Do you have any other insights regarding these financial leaks and structural problems you'd like to share with our audience?
That's a very open-ended question. I should, right?
I think that was done on purpose.
I think the I think what on some level, the insight is, like, we did this webinar because we knew that folks would be interested in raising their revenue and plugging these leaks and having better retention. Like that's sort of a no-brainer, right? And I think the thing that we learned when we did it, we were obviously super excited. We're like, wow, we just found $13 million for our client. Hooray, right? Like the engagement has more than paid for itself by tenfold, by 20-fold. The thing that was really, but that's not actually, like, at Agilian, that's not what we're really motivated by. We're actually really motivated by having people have better health outcomes. So when you realize how bad it is for folks. Like the care workers would share with us, when somebody gets disenrolled from the plan and they get, in some states they get randomly assigned to a new plan, which is a little bit like, wow, really? That's the best we can come up with. But they get randomly assigned to another plan. And a very predictable outcome for that is that they won't actually get treatment for a year. Like they've got to switch providers, they've got to figure out their whole provider network thing. Like these people are busy and stressed out already. So, like we've heard stories of people not, no longer getting their diabetes treatment for a year. And that shortens life, right? And if it doesn't shorten life, it makes it makes, as people age, them have a less quality of life, right? They're less likely to walk. So these are very, very high stakes human conversations that we're having, and it would be cynical to not talk about that side of it, right? Like, so when things are, listen, I used to be the chief technology officer for the District of Columbia. They had 90 different agencies. They weren't integrated with each other. There were lots of pass-offs between them. When things get messed up in the handoff between enterprises, it hurts everybody, right? It hurts the MCO, it hurts the patient, it hurts the regulator, it hurts everybody, right? It hurts their families. Like it creates stress on the community, right? Like we don't want to break our arms patting ourselves on the back for like we did something good, but like just by avoiding doing something terrible, that's important too. And structurally, if you can fix that in a way that you not only fix it, like it's not, the numbers aren't that big, right? Like it's like we found, let's say 2 or 3 dozen people at this client to save them the $13 million. But if you do that this month, and then you do it next month, and then you do it next month, and you do it next month, and then we got into this looking for stuff from the unwinding, right? Like, and we found a bunch of unwinding ones in one state. In the next state we moved to, we didn't find any unwinding problems. We found problems that have existed forever. Like these leaks, they were leaking before the unwinding. So they could have saved the $13 million last year, and they could have saved it the year before and the year before that. And in Medicaid, the way that Medicaid is regulated, only 15% of that can be profit. 85 cents on the dollar goes back to clinical care for somebody, right? So we're just kind of pretending to be financially driven here. Really, the truth of the matter is we're really excited about the 85 cents of care that everybody gets when you save this. It's good for the community, it's good for the individual, it's good for the plan, it's good for the regulator because they're not going to get fined by CMS.
Any insights from you, Diane? Thank you, Jamey. That was excellent. Appreciate it.
Nothing to add. I agree completely.
We're so glad we found you, Diane.
Happy to be here. Happy to be here.
Well, on behalf of the Agilian staff, I want to thank each and every one of you for being here. Thank you to our presenters. And most importantly, we want to say welcome aboard and welcome back to the folks that we've seen before. And we look forward to seeing you at the MHPA conference and our next webinar on the MCO series towards the end of September. So come on back, look for the links. Also, be on the lookout for the follow-up email. And thank you again for your time today. Take care, and we will see you next time.
Great job, Barry. Thank you.
All right. Thanks. Bye-bye.